So one of the principles behind this mild stimulation theory is that less is more, and for some patients this is actually true. And let's go on and look at some of the protocols that are fit for that. So we'll talk a little bit about the rationale behind that kind of stimulation. We'll talk about minimal stimulation for normal responders. Sorry. And then minimal stimulation for poor responders. We'll talk a little bit further about letrozole because some of the previous lectures were discussing more about clomiphene, so letrozole is another option to do minimal stimulation, and then we'll talk shortly about modified natural cycle. So the rationale behind this stimulation is that supraphysiological hormone level does affect the endometrium, the oocyte, and embryo quality. And the combination of early follicular clomiphene citrate or aromatase inhibitor, followed by the gonadotropins, may help us to postpone the FSH start to cycle day 5 or even a bit later in antagonist protocols, and that could achieve a late start with a lower dosage. We know that less medication and cost and less patient discomfort and maybe less multiple pregnancies will help us lower the dropout that some of us have from our programs. Now, I'm sorry. If we look at some older studies, we know that the cumulative live birth rate was not different if we look at a total of 12 months. So we understand that during that time, there were more pregnancies with the normal IVF with the higher stimulation, but if you look at that time and the patient is patient enough, we can achieve the same amount of pregnancies. As for euploidity in minimal stimulation cycles, there are nice evidence that show that we had actually lower aneuploidity in the minimal stimulation. So if you look at these two cycles, we look at the oocytes, so that's the number, these are the conventional, these are the mild, so you see that these become lower because there were less eggs. But if we go to see the embryos, we see that there is the same amount of euploid embryos in the minimal stimulation as in the normal stimulation. So usually when we think about minimal stimulation, we'll think about our poor responder. But I came across this study that I wanted to show you that was published this year in the Gray Journal, in the Journal of the American Society. So they were comparing minimal stimulation IVF with conventional IVF in the regular patients. So they randomized at the end 285 persons to the minimal stimulation and 279, so almost the same for the high dosage group. So let's look a little bit about the protocols that they used. So for the minimal stimulation, they started off with birth control pills until hormonal suppression was achieved, and then started with clomiphene citrate, 1 pill a day, that kept on going until the end of the cycle, and adding to that low dose of gonadotropins from the beginning. So this is a little bit different than what we usually do in minimal stimulation. We usually start one and then add the other, either by overlapping or just one after the other. They started them both together and keeping the clomiphene citrate to prevent ovulation. And then when they had 17 or 18 millimeters follicles, they went on with triggering with GnRH analog with nasal spray, and then went on to collect the eggs. They did a frozen transfer after that. So it wasn't fresh, they froze the embryos, and then did the frozen transfer after that. Whereas for the conventional IVF, they took regular long cycle, starting with daily Lupron or daily GnRH agonist, adding to that the gonadotropin, so that was a standard long protocol, collecting the eggs and then doing a fresh transfer. Now the other thing that is important to emphasize was that they transfer 2 embryos on the fresh cycle comparing to 1 embryo with the minimal stimulation. So that's another maybe weird way to compare these things. Now look at that, this is interesting, that was the results. So we can see that they had, we could see that they had live birth rate that was always a little bit less in the minimal stimulation, as would be suspected, but they was bribing that they had so much less multiple pregnancies. So if you want to look at that, I'm sorry, I didn't say that they were only transferring blastocysts. So one frozen blastocyst in the minimal stimulation, 2 fresh blastocysts in the fresh cycle, and if they had surplus embryos that were frozen, that kept on month after month, 1 on the minimal stimulation, 2 on the regular stimulation. So of course they got more pregnancies with the regular stimulation, and of course they got more multiple pregnancies with the regular stimulation because they transferred 2 embryos. So that statistics was kind of weird, but I wanted to show you that still, at least in my practice and in many others, we keep those minimal stimulation either for patients that cannot afford, if they are regular responders, either if they cannot afford the regular medication, or otherwise for the poor responders. I think that there is a limited place for minimal stimulation in the regular setup of a patient that can afford the treatment to, sacrifice a little bit the quality of that treatment. After this publication, there were a lot of literature that came out that said that the methodology was improper, but never mind. Okay, so let's talk a little bit about our main thing that will be minimal stimulation for poor responders. I want to show you again the Bologna criteria that we all know, and we keep on looking at that. So advanced maternal age or any other risk factor for poor ovarian reserve, previous poor ovarian reserve, or an abnormal ovarian reserve testing. Let's talk a little bit about letrozole. So letrozole is one of the aromatase inhibitor, is the one that is mostly used in infertility. This is a potent and highly specific non-steroidal third generation aromatase inhibitor, originally approved to use for postmenopausal women with hormone receptor positive breast cancer. So whenever I prescribe, we need the special permission to prescribe this drug in Israel, so I have to tell them, if you Google that, you see breast cancer, so I don't worry that you have a concealed breast cancer, we just use it off-label for fertility. It inhibits the aromatase, of course, and it's very cheap. So what does it do? It actually decreasing the early follicular phase estrogen synthesis, and by that decrease the estrogen-mediated negative feedback on the hypothalamus, and it also increased the endogenous gonadotropin secretion. By doing that, we find that the intra-ovarian level of the androgen and increased FSH receptor expression on the follicular granulosa cell, we think that that will help us to increase the response to FSH in poor responders. So that was a study that we conducted during my fellowship in a clinic that we worked. Unfortunately, it's a retrospective, but the data was very interesting for us to publish. So our protocol was using letrozole, 1 pill a day, so that's 2.5 milligrams starting from cycle day 2, and then keep on giving that for 5 days, overlapping with the low dose of gonadotropins of Menopur for 150. That was for the 3 days of overlapping, and after that, usually 5 days, and after that, we could increase to 225 if we saw those nice medium-sized follicles that we could get and achieve. Again, retrieval was done when these follicles were 17 or 18 millimeters, and we compare that to our regular high-dose antagonist protocol that used 300 or 450 units per cycle per our poor responders that we used at the time. Again, HCG was given at 17 millimeters. Now, these were our results. So you can see that there weren't any significant patient between the patient themselves. One thing that is, of course, obvious in minimal stimulation is that the peak estradiol was lower in the minimal stimulation, and the gonadotropin dosage was lower, but this was also, of course, accepted. But look at the pregnancy rate. So we actually had much higher pregnancy rate and much higher birth rate with the minimal stimulation. And that was quite astonishing because we thought that that's the thing, but we saw more pregnancies with that. So the mild, so that was one publication. And then let's look at some of the prospective studies. So Ravelli compared mild to long protocol. They recruited 695 patients and did clomiphene citrate versus long protocol, so using clomiphene instead of the letrozole. They found significantly shorter follicular phase, lower consumption of gonadotropin, of course, and lower estrogen that will be always with minimal stimulation. and then significantly less cycles were canceled due to lack of ovarian response, and they had more embryos and thicker endometrium in the long protocol. But as for the final IVF outcome, however, the two stimulation regime obtained comparable implantation, clinical pregnancy rate, and ongoing pregnancy rate, using much less gonadotropin with less stimulation. Another study that I wanted to try to see if somebody published which is better for minimal stimulation, the Clomid or the letrozole. So there was one publication that was looking at that, Rose from 2015, and they didn't find any benefits to one versus the other. So whatever is easier for you to use, either the Clomid or the letrozole, you may be using that. Let's talk a little bit about modified natural cycle, which is another kind of minimal stimulation. So again, the background for that was at the beginning of IVF. Edwards and the first IVF cycle were always using one egg, but then these cycles were abandoned because they were all the time early ovulation before the time of the GnRH antagonist, until that was put in, and then all of a sudden that modality came back. So we will do usually natural cycle for poor responders. This is some older data that was published. So fertilization rate is fairly good with lower cancellation rate, and with their two studies was about 18% of pregnancy rate. I'm not sure what was the population there. So let's look at this study that was published last year, looking at the live birth rate after modified natural cycle with high-dose FSH stimulation using GnRH antagonist in poor responders. So that was a retrospectively study, including 161 patients that did the modified natural and 164 that went through high-dose FSH. That was, these are the characteristics of the patient, and look at that. So the estrogen, of course, was lower, as we can see, and the total gonadotropin, again, was lower. Number of oocytes retrieved was statistically significant lower, and the number of good embryo again. But if we look at the, I'm sorry, they did, let me go back. If we look at that, after that they went on to analyze their data, looking at what other things were different in between these two groups. And they found that age, they found that number of previous attempts, basal FSH, I'm sorry, and the case of infertility were different, and then they went on to do a multivariant analysis. And that was pretty amazing. So multivariant analysis, including all these variables, comparing the high-dose FSH as their standard with the mild natural cycle. So look at that. The mild natural cycle had odds ratio of 15 more pregnancies than the high-dose FSH after going through the multivariant analysis. And so they did that once looking at all the embryos they got and once looking at only the high-quality embryo. So looking at the high-quality embryo again, odds ratio of 8. So that was really much more than what was expected from the high dose. There was a Cochrane study that was published 3 years ago looking at natural cycle in IVF for subfertile patient, and their conclusions at the end, looking at almost 800 women, said that there was no evidence of statistically significant difference, so meaning that that wasn't better, but it wasn't lower than giving all these injection to the woman. Looking at the this pregnancy rate, they said that if a woman was about to have 53% chance of live birth using the standard IVF, then the natural cycle gave her 34 to 53, which wasn't significant, and they concluded that there was no other difference between that. So concluding, we looked at the minimal stimulation using either letrozole or clomiphene as a good alternative for patient with poor response, and then we looked a little bit about the modified natural cycle. We have to tell our patient what our expectations. So if the patient comes to IVF and says, okay, I have to have 10 oocytes, and then we do a high dose and we get 2, and then I go to do a minimal stimulation, I always tell the patient, we're not aiming to get those 10 that we wouldn't get. I'm aiming to get 2. So if she has 2 follicles, she's not disappointed of the cycle. And then from these 2 follicles, many times we achieve a pregnancy, and then everything, of course, everybody is happy. So when I was looking at that, I found this funny citation by Stanley Elkin, which is an American writer. He said, "I don't believe less is more. I believe more is more. I believe less is less. Fat is fat, thin is thin, and enough is enough." So thank you.